Hello, all. This is Dr. Dheeraj Masapu. I'm a consultant neuroanesthesiologist, and today we have Dr. Kajal, who is a professor in the Department of Trauma Anesthesia and PGI Chandigarh. Welcome to the interview, madam.
Thank you so much, Dr. Dharmendra. I'm very glad to be with you at this platform today to talk about trauma anesthesia.
Madam, our audience are mainly the MD anesthesia first and second year students, and they would like to know. Many people have actually requested for a video on trauma anesthesia DM, which is available only in your hospital in India. And so basically, nobody has a clue about what trauma anesthesia is and what actually a trauma anesthetist does. And also, actually, briefly spoke to you before. Now I understood a little bit about what you do in emergency, OT, and IC also. So, little bit, can you tell the audience what trauma anesthesia is? So it would be helpful. Yeah.
First and foremost, I must say that I am very heartened and I'm very glad to hear that residents who are doing the training in first year and second year have started thinking about trauma. Because at the time when we were doing our MT, trauma was hardly ever in our mind. So the specialty is gaining interest. That is my first, that's a good signal for me. So when I say that what is all trauma anesthesia and why I should be pursuing trauma anesthesia, I would say it's a different subset of patients who require active resuscitation from anesthesiologists. And most of the times when we are not present in the trauma bay and the patient is being managed by our surgical colleagues, so we see that the golden hour is of course missed. And then there are many more such missed opportunities in the trauma bay, like patients are not resuscitated properly. Then patients have concomitant injuries, like they'll be having facial-maxillary injuries, then they'll be having head injuries, and so they may be even like having low hemoglobin, coagulopathy. So trauma presents a very different picture to what we were taught earlier. So when I was a student, I would only think of trauma as doing general anesthesia. So general anesthesia is very small part of anesthesia in the segment of trauma anesthesia. I would say it should begin right from the trauma bay, where our residents should learn how to receive these patients and look at the head end of the patients. We are doing intubations in triage, but mostly the intubations in triage are done hurriedly, and most of the places do not have a protocol. So our residents can start right from there. And some of them are even very keen in intensivists and physicians in their own heart of hearts who wanted to pursue intensive care medicine or medicine, but they've landed into anesthesia. So I would say here's another opportunity where you can again have a contact with the patient, where you can actively resuscitate, do a good intubation, especially those who are obtunded, agitated. You can do a neuro intubation. You can prevent their further insults, and then you can do resuscitation. Nowadays in foreign countries, A&E is a separate department. So when it's a separate department, it becomes on us how to give resuscitation, acute pain management, and then also do on arrival blocks. So this is one small part which our residents can do out of the big chunk. In this is happening in the triage. So I train my residents to go and do active resuscitation as well, like understand the blood gases on arrival, and then see whether they would like to give massive transfusion or blood transfusion or products. So everything starts from there on. And since we have developed our course, we have seen that patients are being managed better when they come to the theater. They've been already resuscitated well, and then they behave well on the table, and they're likely to be extubated, not requiring ICU, and they can be sent back home also without much comorbidity if the patient is having a lesser abbreviated injury scoring. So there's another language for us which we have to learn, like what is injury severity score, what is AIS, so what is GCS. So everything changes when you come to trauma. So our residents would initially always score these patients on ASA, but we all know that trauma happens in the young age only. So it is another score which we have to use. So we are trying to train our residents that you have to see another score. So everything about it changes. So first is that trauma bay, in which residents have a big exposure to resuscitation, acute pain management, and then bringing the patient to theater or intensive care or discharging back either way. So if the patient comes to theater, what I've found is that as our residents are getting more empowered, they are the first one to see this patient, because most of the time consultants would not be on the floor. So I have seen that when they come with concomitant injuries, especially with the obtunded GCS, they are like having concussion and they are not having actually any significant, CT finding. They had the propensity to, postpone these cases because they were scared that this patient has come after 24 to 48 hours of observation. Now, if I anesthetize, then my patient will not get up, is likely to require ICU, and so on and so forth. So this is one segment which residents are able to understand very clearly how to go about managing patients with concomitant injuries. So those residents who are not trained with us, or for that matter, even some younger faculty who are not trained with us, they have the more capable chances that patient is getting postponed more often, because now he has facial-maxillary injury or he has head injury, he is obtunded, he can't open his mouth due to pain, trismus, whatever. So this is the way they build on their confidence, because these patients, they do very well if you do a good management. So I would say airway management in trauma is very challenging. First in the triage, then even in the theater. You get C-spines, which is again a very difficult subset. Then you get, facial-maxillary injuries, which is again a difficult subset. And then you get to know more about these patients. Then also there are so many other things which you get to know when massive polytrauma happens, especially crush injuries. So residents are tuned to managing AKI, and then rhabdomyolysis, sepsis. So these are big things which they get to learn in orthopedics theater. In plastic theater, I've said that they get to do a lot of brachial plexus. They get to do a lot of hand surgeries, complicated hand injuries, and that's how we develop our skill. Then in traumatic head injury is itself a very big thing to learn and understand. Then traumatic coagulopathies, and so there are so many things they have to learn which they have not done in their MD curriculum. Here in MD curriculum, we mostly train them to do spinal epidural and GA, with a little bit of, say, head injury component added to it, and maybe like femur fracture, and that's the main thing which they learn. But here the ballgame is altogether different. So airway management, resuscitation skills, then management of complications of acute trauma like sepsis, rhabdomyolysis, AKI, everything a resident learns. So if the patient goes to ICU, then they see a different spectrum. Say they see a lot of ARDS because of BTC, fat embolism, sepsis, and then they see a big whole spectrum of management of head injury. And then they also get to do a lot of, cases of, we have also developed the program of organ donation. So if your patient doesn't do well despite your best efforts, then you open the dialogue for maintenance of potential donors. So our residents learn that also in the same ICU. So this is this is just a very bird's eye view which I'm giving you. But what we see is that residents are developing a big skill on the use of all these things.
Superb, madam. So basically, from what I understood is from emergency, OT, and ICU, there is a different ballgame actually. It's because polytrauma itself is a kind of SIRS. So the patient will be in a different shape actually when he comes to the OT. So you better to optimize him before, give blocks, and then maintain him and manage him well in the post-op. The outcome is totally different. It is what is.
And resident learns lots of interventions. So our residents are also keen on doing interventions. So the key interventions which they do are placement of ICD. Of course, intubation and all is everybody's. Like my residents are very trained to do ICDs. They will not call anybody to do ICDs. They can place ICDs themselves, and they can do lung ultrasound and pick up lung findings. They can also do E-fast. So they learn how to look at E-fast and take a call on how to go about it. They are also doing optic nerve sheath diameter guide the management, TCD, transcranial. So, and plus ultrasound guided nerve block. So the ultrasound is being used quite a lot in trauma settings, and the residents are doing interventions based on ultrasound. So my residents will place chest tube on doing lung ultrasound. They will say there's an effusion, there's a pneumothorax, Their skills are developing. They
Okay.
also get to do a lot of percutaneous tracheostomies. So
Okay.
all those residents who are trained to do percutaneous tracheostomies can save a life. So
Super.
all life-saving skills anesthesia residents are empowered with when they work in trauma.
So what I understood is after doing this course, they can either stay in cities, metros, or even in towns. Actually, they can set up their own hospitals and emergency centers, I think,
Yes.
because they can manage the whole range of situations now.
And the best is they can save so many lives because
Yeah.
they have been trained to save lives, but somehow the interface is lacking. Mostly the first point of contact for a trauma patient is a general surgeon or a general physician. So their skills cannot be equated with the skills of an anesthetist. So that interface is lacking. So by the time patient comes to us, patient has suffered secondary injuries, due to which they have morbidity and mortality. So our residents can do a big favor to our country by being at the point of first contact of patient in any hospital.
And I have done research about the trauma anesthesia in other countries also, madam. Not many countries have the fellowships actually. In USA, there are only two hospitals like Maryland, Baltimore, and UCSF has fellowships.
Yes,
In UK,
yes,
I
yes.
didn't find any hospital providing a fellowship. I didn't find, maybe you must be knowing. Very few centers are there.
Yes, actually, there they have developed the first responders by paramedics. So most of their work is being done by paramedics or trained EMS doctors. So some of the doctors they take special training in EMS because they want to start doing resuscitation right from road to safety. So in our country, I do not know how we are going to progress further, but trauma per anesthetist forms one part of the trauma team. So in our hospital, it was decided that trauma will be handled by a separate team of anesthesia and will impart a special curriculum course to residents who want it.
Madam,
So
that's true because first you started now. Slowly, other hospitals like AIMS will start next and CMC will start next. It will slowly go on like that. Neuro anesthesia also started like that initially.
There are hospitals who have started fellowship. AIMS Bhubaneswar has started. Then Sanjay Gandhi Lucknow has started. BHU has started. And AIMS Rishikesh is in the process. And AIMS Delhi is in the process of DM course.
Okay. But doing a DM will make more sense because I think all the skills will require at least 2-3 years to learn.
Yes,
In 1 year, it
definitely.
is very tough to learn whatever you told. To master it
Yes.
will take time.
First, we have to understand what we have to do because people used to ask me from All India Institute also that how do you make your teaching curriculum? I have been in trauma since 2011. For the last, we started our first course in 2018. So 6-7 years was enough for me to understand the landscape of trauma. And of course, I follow a lot on Google and other hospitals, like what they are doing. From there, I have drawn my program. Like we do a lot. We teach a lot about resuscitation. We don't talk only about anesthesia. Like we don't say like C-spine anesthetic management. No, we talk about how to apply collar, mills, intubation, neurogenic shock, and then a patient with C-spine on ventilator in ICU. So we get a complete spectrum. It takes about 2 to 3 months to finish cervical spine, and it takes 4 to 5 months to finish, like 4 months maybe to finish TBI. Then abdomen 2 to 3 months. Then so on and so forth. Like blunt trauma, chest and fat embolism. It's a very daunting and challenging task. So, but with expertise, our residents are able to give very good outcomes.
So now I think till this part of the video, students would have understood what actually trauma anesthesia covers. So next part we'll just cover how the career, like who should choose it. Like can anybody choose or some kind of personality people should choose? That is what.
I just told you those who were desirous, who had a keen intensivist into them, and those who were also interested in pursuing medicine, but for some reason they didn't get it. I always tell my residents, this is the second chance for you. And then, of course, those of my residents who joined initially, they joined because they were passionate. But then once their passion penetrated through other residents, then others also got, very motivated. And currently all my seats are full. Even my foreign national graduate post has been taken up. So it is all about awareness, and it is all about knowing, because in today's generation, I think everybody wants to have a skill set. which is unique from others. And this one offers anesthesia, like you are always, everybody can do anesthesia, put a tube, but putting a tube in a compromised physiologically difficult airway and a coagulopathic patient, doing a procedure and all, it gives you a different feel. So I asked my resident, what do you like? They say it's challenging every day. We are not bored. When we come, we know what we are doing.
Madam, my next question would be this: is it exhausting every day to actually, like jumping and running, and it is a different kind of like how
I
is it?
don't know. I'm touching 55 plus, but I am not exhausted. So it's all how much energy you give to your residents. Even sometimes I have to tell my residents in the morning, please go. You are here for a long time. So when I go in the morning at 8:30, I see them lurking around in the corridor, waiting for me to discuss some cases and all. So I have to tell them, please go. You have been working too long. Please go. So that just speaks that they are not, exhausted, because they're enjoying the work. It's a very dynamic. It's very dynamic, in trauma. You don't get the same kind of spectrum. Something is there for them to see. And once the patient starts improving, say, I see so many of my residents are very motivated to do crush injuries. They will follow all the protocol designed to manage, myoglobinuria and AK. When I go in the morning, I see that everything is done nicely and properly. And once you get that energy, nobody feels exhausted. Okay, if they do something, they get a video laryngoscope and they're intubating a difficult mouth opening and they're able to put the tube, the energy is automatically doubled.
Understood, madam. When they get to do some challenging work, the energy builds up actually. Understood.
Yes. And then next day, when you discuss with the case with them, we have a habit of discussing our cases daily, because these are new cases. So we have developed this over the last 1 year or so, that we would like to see our own cases in the morning. So what happens is, normally anesthesia people, they'll go off, they'll give over, and the cases are, not discussed. So since it's a new branch, my team and I have thought about it, that we will discuss our own cases. So we discuss, why did I postpone this case? And why did I do this case with so much of derangement? And sometimes I'm like, awestruck by the way they do difficult cases in the night and put them on ventilator. I said, did you do this case? It is so difficult. I would feel then that this is the kind of energy my residents are having. Like, I'm very praiseworthy of them, that they are doing a fantastic job.
Superb, madam. So one of my subscriber has asked a question for you, madam. And actually, question is: are there any international exchange programs that you are planning to do in future? Is the question we wanted.
Absolutely. See, my first endeavor was to create a society which runs educational activities, so that we can talk more about trauma anesthesia, not trauma anesthesia and related fields. So last 3 years, 2018, 19, 20, we have been running one annual small CME, and we have been roping in international faculty. So first, to develop this collaboration, you need to tell them you're doing something. So they do not know if India is doing anything, right? So we have now developed that bond, and we are trying to, make them more aware of what is happening at India. We have written a book also, which is conducive to Indian perspective. And now, after so many years, I'm finally able to give one international conference in November at PGI. I'm trying to rope in emergency medicine guys. I want them to come and see first, like what we are doing. So once they see and see the kind of patients we get, the spectrum of patients we get, only then I can open the dialogue. If I start opening the dialogue before showing them the bigger canvas, then maybe it will burn out in a year or so. I want to sustain it. So we are calling, I think, 8 to 10 international faculties, and some of them are deeply into emergency medicine, into A&E. So we intend to talk to them and show them around, let them take some lectures. Some residents will be sitting and asking questions, which will be again, building up more, confidence into them that this is the branch I want to choose, because somebody will be talking only on trauma. See, you go to ISCCM conference, they do give trauma a slot, but it is only 2 or 3 hours. And then it is like critical care. You go to ISA, it will give a trauma session, but again, 1 or 2 hours. Nobody is talking only about trauma for 3 days.
Got it.
Yeah. So that is the reason. So I want first to build that relationship. Once we are 5 years strong on our program, which is already running into the 3rd or the 4th year. So maybe then if somebody says, yes, we have been asked by some army guys, like for exchange program, some paramedical troopers, they do come to us for seeing our patient profile and everything. So somebody asked me the other day, can I send my resident? So right now we are only on national collaboration, but yes, this is on the pipeline.
Got it, madam. But in the beginning of the course only, I think it's better to take up, because when neuro anesthesia was beginning in the DMs, so whoever has done that are actually heading the departments in places. In the same way, I think it is beginning now. I think in this
Yes.
space, whoever enters will become leaders in future, I think so.
Definitely.
So then one more subscriber has asked a question, madam. What will be this question is simple, job opportunities after this, after the DM is the question. So
Yeah. So regarding job opportunities, sadly, like right now, trauma anesthesia is in a very initial stage. But I have been taking interviews, and I have seen that AIMS and AIMS like institutions are having seats now being advertised only for trauma anesthesia. But right now, their minimum requirement is not DM, because DM is being offered only by PGI Chandigarh. But having said that, it is in the mind. And even Government of India is very keen on developing trauma, because they're opening numerous trauma centers. They may not be level 1, but level 2, level 3. And we don't have to start with a very big foot. We can make some baby steps also. So recently I had the chance to address Punjab state, where the traffic cops and bureaucrats, they had called us to discuss how we can improve trauma in the state of Punjab. And they have trauma centers, but they do not have specialists. So the problem is both ways. Our doctors are not getting jobs, and they are also not getting doctors, because trauma requires passionate people. It cannot be done by people who are not passionate. It's 24/7 job. So if you're passionate, only then step into it, because it's a 24/7. You can't wear a watch and go. So that's what I told them. It's passion driven. From 2011 to 2023, I have worked a lot. I haven't seen day or night, because we wanted to progress. So today I'm able to say all this because we have got 13 years odd experience behind us. First understanding and then talking about it.
I understood, madam. The essence of what you're telling is basically it's evolving. So we have to start actually somewhere and build it. So that is how it is going to be. Even corporates and other hospitals also slowly will start the trauma divisions, I think so.
Yes.
So that is how it is going to be. So then anything else you would like to add, madam? I think this much information is adequate. So what kind of preparation they should do in their MD time if they plan to do DM in trauma?
So I would say, like, they should strengthen their resuscitation skills. They're already very skilled at doing airway management. So airway management is our forte, anesthetists. So they should manage their resuscitation skills, because trauma is all about resuscitation. They should know how to, manage a patient during the first 1 hour, and then when for the secondary injuries, and then intensive care management of a trauma patient. So what are the how do we need to look after our head injured patient, how to look after their ICP monitoring, and then fat embolism and ARDS, sepsis, AKI, the usual. So they get to see a lot of critical care, which is not related to medicine. Here you see patients 18 to 60 years of age. In critical care medicine, you see maybe the other side, and you see MIs and all that stuff. So here I must make a mention that I have had the chance to manage the most exciting cases, which would otherwise die on the road. That is thoracic aortic injuries. So that is also very challenging. So we have had, since we are like now coming of age, we have seen, I think last month I saw 4 of them, out of which 2 of them could not make it, but 2 of them survived. So the mortality is very high. So they get to see a lot of different kind of patients also. It depends, like, surgical fields also, if they grow, then the anesthetist also grows. So if they give good results, then surgeon also feels encouraged. They also bring in patients. They discuss, and then they're very happy to see good results.
I think trauma surgery also should grow along
Absolutely.
with.
Absolutely.
Then both will grow together.
Then it's like a win-win situation.
Yes. MCH trauma surgery is there. They should actually they will hire trauma anesthetists and they form teams and it goes on like that, I will say.
And those residents who are interested in knowing more about it can participate in the forthcoming conference being held at PGI Chandigarh from 2nd to 5th under the banner of Society of Trauma Anesthesia and Critical Care. So we are teaching only trauma related stuff like trauma resuscitation, trauma related acute pain, trauma related chronic pain, then trauma related anesthesia blocks. Then there's a full blown workshop on point of care ultrasound. And we have international faculty teaching all this. First 2 days we are dedicating only on hands-on workshops, and the next 2 days are lecturing. And we are also including paramedics, traffic cops, and nursing to complete the list so that everybody's on the same page when we manage a trauma patient.
We'll put the link in the description of this video, madam, so that they can easily access to the website.
Okay.
So thank you very much, madam, and very delighted to have you in the channel and a lot of information you have given. And hope the trauma anesthesia becomes a very
booming branch.
Yeah.
Booming branch.
Booming branch. It's in the beginning, budding stage now. I think it will be a booming branch in future. But I've seen neuro anesthesia also like this. When I was a third batch of neuro anesthesia in the MANS. So at that time nobody was knowing about that. But slowly now everybody knows. So,
now it's a big branch. Correct.
So in the same way, this also evolves for a period of time. And so I recommend my subscribers actually to get into trauma anesthesia, because after talking to you, I understood the scope of the program and what skill sets. Actually, I'm feeling like I should maybe join the DM program maybe and read.
So I love that statement of yours. So my day is
Okay, madam. Thank you very much. And
thank you.
Thank you.
Thank you very much.